webinar. We appreciate you taking the time out of your day to join our special topic webinar today on music logic models for FLEX program planning, management, evaluation, and reporting. The FLEX program is moving towards implementation of national measures as a framework for demonstrating the impact of the FLEX program funding nationally. And so this is placing a greater burden on the state FLEX programs to develop and implement program activities and connect their program activities with outcomes that can be captured and reflected by specific attainable measures. So the program logic model is being introduced as a tool to assist states in planning their program activities, describing the rationale for their interventions, identifying outcomes for the interventions, and managing and evaluating their programs, as well as providing that direct link between the program interventions and activities and the program impact, not only just in the state, but then ultimately to be able to tie everything together nationally. We're joined here today with John Gale from the Maine Rural Health Research Center in the University of Southern Maine as our content expert to explain the program logic model. The University of Southern Maine is one of 3 universities that makes up the FLEX monitoring team, so we're really pleased to have John here today to share his insight with us about the program logic model and its use within the FLEX program. Before I turn things over to John, though, I just wanted to ask if there's anyone from ORHP that wanted to make any comments about the use of the logic model or the direction of the FLEX program.
Just a reminder to unmute your line. You please press *#.
All right.
You're not alone.
You're not alone, Tracy. Evidently, I don't pay attention either.
Great, thank you.
So, along those lines, I just want to say that ORHP believes that this logic model is a good start to be incorporated into the work plans for this upcoming and future project years as we go forward. We want to make sure that this is a good example of how to set things up, but that there is still room for variation in your applications. If there's one thing to think about as you're going forward is that as you're applying what you're learning here, think about how it applies to the need of the program, the need of the facilities, the help, and that everything should be linked back to that. The overlying theme here is with FLEX, we're here to assist, and there has to be a good reason to assist, and that's what we're going forward at. But I don't want to take any time away from John's presentation, so back to you.
Great. Well, thank you, Mike. And with that, I guess we'll turn it right over to John then to get started with the content for today. And we look forward to hearing more about the logic model and its relationship with our previous webinar where we talked a bit about outcomes and outputs. So with that, John, please go ahead.
Thank you. I appreciate you all calling in today. Just go over briefly what I hope to do today, and we can be informal. I've got an eye on the chat screen, so if you have questions and want to use that, that's fine. If, as we go along, you have a question that you want just to raise, you can use the unmute function and just ask at that time. So don't feel the need to wait to ask a question. We can address things as we go. But obviously the logic modeling is a tool, and it's simply that, and it's a way of thinking about how to construct and plan and organize your program, but it has a lot of uses beyond just the evaluation piece, and that's what I wanted to talk to you today about. I haven't focused as much on the specific measures contained in the guidance. You've all had plenty of chances to hear about that, but I wanted to look at a way of sort of rolling everything up and sort of think about and present some ideas on how to think about moving towards outcomes and measurement for your programs. Obviously, as Mike just said, there's a lot of, the program is really moving towards a much more accountable structure in a way of proving and providing evidence of program impact. This isn't new. This is really just a continuation and I think an evolution of where the FLEX program has been going for some time. And it goes back to even the strategic planning outline that's been on, at least had been on the ORHP website for some time, which was really, and one of the major objectives was to monitor the effectiveness and efficiency of the program and grantees associated with FLEX. And there's no surprise, there's real vulnerability of the program, rural programs in the federal budget at the moment. You have Government Performance and Results Act, the GPRA, and really it's a great internal planning tool that you can use to communicate information about your program in a very, very concise way. I was going to say simple. These programs are not simple. They may not be huge in terms of overall numbers, but you're looking at some very complex situations. And we're in an era of accountability. I adapted this from a book that had been getting a lot of attention for a number of years in government. What gets measured gets done. If you don't measure the results, you can't tell success from failure. And if you can't see the success, you can't reward it. And if you don't see it, you can't learn from it and duplicate it. And I think that's the most important piece here, is that the learning collaborative, if you will, of the 45 state FLEX programs have a wealth of information and success and experience that unless we can begin to measure it, we can't really build on that success. So this is nothing new. And look at simply at the couple of definitions for the logic model. I always think it's helpful to think about why we look at this. Logic is the principles of reasoning, reasonableness. It's the relationship of elements to the whole. And understand that we're talking about a model now. We're not trying to capture everything in intense detail about your program. It's a smaller representation of the larger program. It represents reality, but it isn't reality itself. And it's really a planning tool. And it really gives you a chance to talk about and think about and articulate the theory or the program strategies that drive your program and by which you hope to have an impact. And it's always interesting to me in evaluating programs over the years that it's not always true that we think explicitly about our program strategies. We may think we know them, we may have an idea of what happens, but it really helps to put it down in very clear terms. Not so much that we don't know, but if we can't communicate that to others, it doesn't serve as a focal point. As I mentioned, it's a visual representation. And this is the piece that I think is the most critical, as I've mentioned, is really describes how the program works to solve identified problems. That should be problems rather than programs within a given context. It identifies the problems. You get to the root causes. You know, we look at a problem. We're concerned that quality may not be good in a certain hospital, or the financial situation, the financial stability of the hospitals in question. We don't know what causes that, so you just can't shotgun an approach to symptoms. You really need to think about what's driving the underlying problem. Then it links the program strategies and your activities to these conditions and root causes and helps you to evaluate the effectiveness. It really describes how your goals, objectives, strategies, activities, outputs, and outcomes roll up into a coherent whole. Here is, and I'm going to share with you a little bit of work that was done by a fellow from Arizona that I had the pleasure of doing some presentations with at various ORHP events and NRHA events over the years. A fellow named Ralph Renger, and I believe he's with the school, had been with the School of Public Health at the university. And he really, his point was that program management, we tend to fall into activity traps. We do things because we've done them that way for a long time. We're not quite sure why we're doing them, and we may be doing them quite well, but they may not be the right things. So we have to think about moving away from symptoms to the underlying cause. One of the things that I have observed over the years with Flex, not only with Flex but with other programs, we tend to fall for the intervention of the month. People get excited about new management techniques, new strategies, whatever's hot in the Harvard Business School literature. And while these all may be good things, and we've got to maintain some consistency and make sure that whatever that intervention is right for your given situation. And the logic model helps you to do that by really thinking about consistency over time. And this is a piece that I particularly liked that Ralph had shared with me, is that he has something called ATMs, and it's a way of avoiding that activity trap, is you identify the antecedent conditions. This is the why of the problem. Why are we doing something? What is it we hope to change about our situation, about our hospital's operations or behaviors that will have an improvement? And then once we've looked at those root and causal factors, we want to target those conditions. This is the how, who, what, and how. Who are we targeting our intervention to? Is it the business office folks in a hospital? Is it the quality improvement staff? Is it the EMS folks in a community? Who's involved and who are we trying to help? What are we trying to do? And what are we trying to fix? So thinking about then if we're looking at the business office, what is the major problem? Is it a cash flow issue? Is it cash management? Is it billing? I mean, it can be something as simple as not sending bills out on a regular basis because something is amiss in the billing system. And huge changes can be made by taking care of the basics. And so it's the what of our strategies. And then how is how we're going to implement it. What are we going to do? If we're looking at the business office again, are we going to train them? Is it a training issue? Is it an equipment issue? Is it a staffing issue? You may have folks, you may not even be able to get a qualified billing person in the hospital, so that really changes and directs how you intervene. You've got to identify your resources and your activities and outcomes. And then measurement, and this is the key and very important in terms of your Flex applications and moving forward, is representing measurement in the model. What are your time frames? How soon do we expect outcomes to take place? And really thinking about a chain of outcomes. Ideally, we want hospitals to be more viable financially. We want them to provide evidence of their quality. But these things happen over time, and some of the ultimate outcomes or goals of the program, which is to improve the health of rural communities, we may not be able to get to that measurement. And there's so much noise in our systems, and there's so many different players involved that attributing causality and assigning the responsibility for the Flex program to fix all of these conditions is not very reasonable. But we can begin to move, and by showing how our programs have incremental steps moving over the short, intermediate, and long term, why we expect changes to take place. Real challenge getting at the sources of data for measures and indicators, so we can't always measure what we'd like, and so we have to figure out what's the best proxy variable, and then how to extract measurable objectives from the outcomes desired. And this is a nice way of thinking about it, and it's a mnemonic that I find useful. As we go through the benefits of a logic model, builds common understanding of the program and expectations for results. It's very important to share logic models not only internally with the staff, but with the people, the hospitals you're working with. They have something to say. They're the vehicle by which your program will have its impact, so it's important to engage them. And it's important they all understand everyone understands what we're trying to accomplish. Facilitates program design, identifies elements critical to goal attainment, links rolls everything up into one packages, resources, activities, outputs, and outcomes. And very importantly, I think it exposes some redundancies that maybe exist, resource bottlenecks. inconsistent and practical linkages between program elements. Sometimes we hope things will happen without good reason to believe that that will be true. Resource bottlenecks are a huge issue. Early on in evaluating and assessing state plans and state programs, especially for the smaller states that might have had only one or two people in their Office of Rural Health and a state office director that might have been wearing both the state office hat, a primary care organization hat, and flex hat. A lot depended on that one person. If that person got sick or that person resigned, program activities ground to a halt. So you have to think about ways in which that bottleneck can be broken and resourced so that you can move the program forward. It always helps to know where that is. It identifies key performance measurement points, and as I mentioned earlier, builds that real strong chain of evidence that can demonstrate the impact of flex. Limitations. They represent reality but aren't reality themselves, so they're a very concise model. Doesn't cover all the bases. It really can't cover all the bases and have it serve as an important tool. It's a focus on expected outcomes, and this is based on a static point in time, and it really has to be revised as the program evolves and outside issues and outside factors come to play on the performance of CAHs. Real challenge of causal attribution. As I mentioned, you've got a lot of things going on, a lot of noise in the hospital environment. You have state government that is making decisions. You have hospital associations. You have economic factors going on in many communities that really can impact the change. And I'll give you an example from here in Maine. One of our critical access hospitals in the middle of the state had been working hard towards conversion and had a very substantial increase in cash flow and financial performance projected based on conversion. Within 3 or 4 days, I think, of their receiving their approval letter from CMS, the major employer in the community, which was a paper mill, closed, went bankrupt, shut down, laid off all of their employees. This was the primary source of commercial health insurance for most workers in the town, with the possible exception of municipal government and the school. The hospital did not have the financial performance that it had expected, because there was something completely out of its control that had an impact, and it's important to know where that can happen. So in using the logic model, there's some important points I think it's worth exploring. Determining the purpose of the model, who'll use it for what, how will it be used, in what situations. Is it an evaluation tool? Is it a planning tool? Are you using it to describe and sell your program, if you will, to others, to convince policymakers? It's important to know that how it'll be used. It's got to be done with the involvement of the people who it will affect. So your own internal staff should be involved, hospital staff, any stakeholders that might be involved. It's critical to set boundaries for the model. You can't cover the whole world and have it do its jobs and be useful. So put some boundaries around what it is you're trying to capture and measure. Very important is explore the research and knowledge base of interventions that you'd like to select. Find out what others are doing, have done. I mean, this is probably at the crux of some of the changes that the office is making around the FLEX program, which is really to focus on strategies, evidence-based interventions that have had a demonstrated impact, so that you know when you're selecting an intervention why and how it'll and that it's worked in other situations, so that at least you have some reasonable sense that it will work if adapted properly to a particular hospital situation. And very clearly also, as I mentioned, understanding the environmental and external factors that may impact program outcomes, figuring out who else might be working with the hospitals. If, in fact, you're looking at a quality improvement intervention and the hospital association or the QIO is doing some similar work around this area, it's best to know and coordinate rather than duplicate and step on top of each other. Go through a couple of stages, and I'll do this pretty quickly, and then we'll move into some a concrete example from the FLEX program. Preparation. As I mentioned, establish the development framework, who's going to be involved, when it's going to be involved, what your time frame is, and figuring out roles and responsibilities. And as you move into the planning program, really thinking about what you want to accomplish is step one. Define the problem to be addressed, and be very, very explicit about what the problem is. It's not just perceptions of poor quality or financial instability at hospitals, but what are the reasons for financial instability in the hospital? Is it a billing issue? Is it cash flow? Is it the fact that a hospital is located in a community and doesn't have that has very little commercial coverage, so they have a high rate of uninsurance? Do they have volume issues? Do they have charge master and cost reporting issues? Figure out what problems are being very clearly and define that problem in a way that lets you communicate that, and then develop what the underlying causes are so that you can identify what you're going to do. I mean, it's the critical planning piece. At the risk of being harsh, there have been over time some tools that have come and gone in favor of, in terms of favor and in terms of interest in the FLEX program. Then it's not to say that any of these interventions have been bad, but they, and one example that I'll use is the balanced scorecard. And please don't get me wrong, I'm not saying that the balanced scorecard is a bad tool. It's not. But a lot of folks adopted it carte blanche and didn't adopt it, really didn't have an idea why they were adopting it, but that was hot, it was big, a lot of folks were, a lot of consultants involved. And while the tool is good, if it's not implemented properly, it doesn't have the impact that you want. So a lot of time and money was spent on sort of chasing the flavor of the month, and I think to the point where it diverted attention from resources, and a lot of that is that there wasn't a connection to the underlying the underlying causal problems that they were trying to address. It has to be something that will be adopted and used and to target the issues that are causing the problems. Step two is getting at your program theory, and that's really describing how your program will achieve its desired outcomes, and what those activities are, and do that very specifically. Who will it impact when? How will it do so? What are the activities? How will we know we're succeeding? And as you think about that, one of the important things, and I keep going back to this, is really describing how the program, how you'll know if you're making progress. You've got to have outputs. You'll have short-term and intermediate and long-term outcomes. You evaluate through that your chain, the chain of evidence, the chain of outcomes that tells you that you're moving in the right direction. And then, obviously, assessing progress using the measures developed. Implementation is stage 3. You really want to get your data systems in place, figure out who's going to, what staff are being assigned, and what consultants and resources are being assigned to implement and support activities, and then certainly monitor the execution of those program strategies. We've all been involved in program strategies where something has come along, it hasn't gone the way you expected, and you've really got to monitor that on a day-to-day basis. And then finally, provide review and revision. There's a feedback loop that's really important to program activities. Just as you defined your problems and defined your interventions at a point in time based on your best knowledge, as you implement, as the environment changes, it's necessary to adjust activities. Maybe one hospital is doing better than you expected. They've discovered something that can be useful for the other hospitals. Maybe the staff that had been at the hospital at the time have left. There's been a turnover in leadership, and they're just not as attached to the intervention or not implementing as you thought. And it's important to know that and change your strategies as you go. This is just sort of a graphic illustration of what we do and how a program logic model works. This is just a very simple graphic that shows you when planning, you start with your end results in mind and move backwards to identify what you need to do. Your evaluation, you continually monitor where you are, and it sort of underlies the process. And you're moving from the left and looking at your situations, identifying your priorities, looking at your inputs, which are and it's probably wise to think about some of the definitions at the moment as we move forward. Your priorities, inputs, resources include staff, cash, in-kind contributions, materials, equipment, anything you bring to bear on your program. Activities are the strategies are the things that we do. We conduct workshops, we deliver services, we provide technical assistance, you train individuals to do a better job around billing or cost reporting. Participation is also called reach, and it's who's involved. Who are you targeting at a given level of intervention? It's always important to have management and the CEO's support and engagement, but rarely is the CEO carrying out and the person is doing the strategies. So really make a clear understanding of who you're targeting. And as we think about it, we have, and here's where we get into an interesting challenge, and it's not always clear. It can be a little bit gray. So we start moving from outputs to outcomes. And outputs are, it's probably wise to think of outputs as the product of what we do. It's the things you can count. So we've had meetings, we've developed trainings, we have resource materials that can be put together. They're the things that you do that are expected to have a change, but they're not the change themselves. So they're really process and interim measures. And outcomes are really much more substantive, and as we go along, I'll talk about them, but you have short-term, intermediate, and long-term outcomes, and they become more complex, and they move you towards your desired goals. And this will sort of illustrate that programs aren't linear. There are feedback loops in multi-dimensions. So as you're moving from inputs to outputs and participation to outcomes, you start seeing how things roll up from your initial investment through activities and outcomes. Outputs and outcomes influence one another, and as does the outcomes, and what you're achieving flows backwards to direct activities. So it really is a circular feedback loop that's very important. What does a logic model look like? I will tell you that the vast majority of the largest benefit from the logic model is the thinking and the planning process. Once you've done that, developing the graphic is the icing on the cake. It's a little bit like the strategy maps in the balanced scorecard. They look pretty simple once you've gotten them down to their essence, but they represent a significant investment of time and brain power and effort to get there. And the ability to capture it in a relatively simple graphic is a function of the hard work that goes on before it. So you can do it graphically with boxes and arrows. You can do any shape you like, whatever works. I'm not a very complex graphics person, so I tend to use tables. But you think about the level of detail. Some of that will relate to your audience. You may want a little less detail if you're presenting to policymakers and you want them to get the big picture. If you're using it as a program management tool, it may be more complex. And given the core areas within within the Flex program and the multiple activities within many programs, it might be worth thinking about individual models. So you might have a quality improvement model. You might have a financial and operational improvement model. You might have a community engagement or an EMS model. But just think about them in terms of what makes the most sense for your use. And as you develop a logic model, always important to check it. And you do that by sharing it with the program committee, with program partners, evaluators, program participants, others involved for comment and feedback. And ask yourself some basic questions. Is it meaningful? Will it have an impact? Will it change the underlying problems? Does it make sense? Is it plausible in terms of where you're moving your activities and in making change? Can it be done? Is it possible to be done within the time frame you're expecting? Is it a reasonable workload for the resources available? And then can you verify the outcomes? We talked about this a little bit, outcomes, outputs versus outcomes, very important. Too often programs measure, the process measures the products and outputs. They are important because they know that you're achieving and your strategies and activities are producing something, but they're not proof that you've accomplished anything other than delivering the technical assistance. The amount of technical assistance, the number of people attending meetings, the number of meetings you've held. These things are important as a measure of implementation, but they're not in terms of program impact. And outcomes are really changes or benefits received and exhibited by the individuals, groups, or organizations involved. They're time-specific. They roll up from less complex to more complex as the time horizon extends. It becomes more difficult to measure and assign attribution or causality as the time horizon becomes longer. You have less and less control the further away you move from the program and the more things that could impact it. And that's where this chain of evidence becomes important. Examples, if you want improvements in hospital quality or performance or financial performance, you've got to measure the things that you're doing that will contribute to that and think about relative contribution versus trying to assign causality for everything that's happening, because it's just not possible. Outcome timeframes. Short term, generally 1 to 2 years. It could be 1 to 3 years depending on your program. And these typically involve changes in participants' knowledge, attitudes, or skills. So if you're focusing on quality, and one of the issues is that the CAH staff are not really as knowledgeable or experienced with QI initiatives and what's going on in the state. I mean, the short-term goal is to make sure that they're aware of what resources are available to them, what's happening, how often that's and how they can access them. Intermediate is 3 to 4 years, roughly, and it involves change in behavior. So if you've addressed the knowledge base among the staff in a hospital, then are they changing their behavior as a result? Are they participating in benchmarking? Are they using benchmarking data to make changes in their clinical quality? Are they, if they're focusing on patient safety, and they've got a falls reduction program, are they actually reducing falls? And there is a question. Catherine, I'll get back to you in a moment because the question is whether the work plan and the next non-competitive guidance is going to change to show outputs and outcomes, or will it remain the same? I think, Mike, do you want to take that one?
With it, we are going to change it a little bit and what's been uploaded. The idea is to show the activities, the outcomes, and the intended impact. So there is a modified spreadsheet that has been uploaded with it. So we are taking that into account.
Great. Thanks, Mike. Your long-term goals are 4 to 5 years, 5 years or more, and these really involve a change in condition or status. So if you've been working on patient safety, you have a benchmarking program, you have a patient safety collaborative, can you then demonstrate, as the program has its impact, that the hospitals are demonstrating improved quality? Are they doing a better job with medication safety? Do they have fewer medication errors, reductions in medical errors? Are their patient outcomes better? Are they showing improvement based on hospital compare or whatever system you're using? So it really it helps to think about it in these terms. So if you're looking at your problem, you've got to educate people on what's going on. You've got to bring them along so they're willing to invest and participate in programs that you're implementing, things that are good for them. I mean, I think a little bit about the MIBQIP program. There has been a lot of work involved in really bringing people along and hospitals along on the value of public reporting. That's really a shorter term. 3 years you want to make, in 3 or 4 years you want to make sure more of the hospitals are engaged in actually doing something with the MIBQIP data. Are they using it to manage and improve their performance? Do they have interventions that are going on? And then over time, are we seeing changes in hospital compare or the publicly reported data that would suggest that it's having an impact? So it's really helpful to think of it in those terms. Look at the legislation for Flex. It really is to improve the health of rural communities, improve the quality of hospitals. Those broad goals are really hard to measure. And when you're thinking about how would you know if you've improved the health of your community? That's so far outside of, there's so many things going on that could impact your success that it's really hard to measure that. So, but if you can say that the people that we've improved access to primary care, we've improved access to services, preventive services, or immunizations, or we've improved access to mental health services. We're doing a better job in improving quality, that more people are using local services. That would logically lead you to believe that you're having an impact on improving the health of the community, regardless of some of the environmental changes. Certainly the people in that community are going to be better off for the efforts of the hospital than they would be in their absence, even if ultimately you can't say that the adolescents in that town are using less substances, or you've reduced adolescent and childhood obesity. So you've really got to think in those terms. And that's that program theory that gives you the evidence to show that your outcomes and your chain of outcomes are having an impact. Yes, I can do that, and we'll get to that in a bit. The question was, am I going to discuss how to measure knowledge change in some of the short term, in the short term, and yes, we can get to that. Excuse me, and then you have to evaluate your change. Do the long-term outcomes represent meaningful and valued changes in participant status or performance? Networking is a good example. For a long, long time, networking has focused on the efforts to bring people together. A lot of networks formed without a real expectation of a long-term outcome. And so you really have to think in those terms. So just bringing people together is a valued activity. Is that enough to justify it unless you can show some change for doing that? Do they relate to one another? Does everything relate to one another logically? A logic model is nothing but an if-then a clarification of the if-then relationships between activities, outputs, and outcomes. So if we do X, Y results. If we produce Y, then it will lead to this outcome, which is a change in knowledge. If we change knowledge, does it lead to a change in behavior and then a change in status? So it really helps to think about it and make sure that that if-then relationship holds up. And are they achievable given available resources? We all overreach sometimes. We all want to do the best that we can, but we are talking about limited resources in terms of time and dollars, and a fair amount of need. I think about some of the bigger states in particular with large numbers of CAHs. The total amount of the grant for, even if a state receives the maximum amount and they've got 60, 80 or more critical access hospitals, that's not a lot of money to go around. So it's always important to plan strategies that are consistent with and leverage your available resources. And are there potential negative outcomes of the program? So you've got we've encouraged hospitals to publicly report. We've gotten them to move along. They're publicly reporting. What happens if you have a particular hospital or two that shows up badly, and by public reporting their quality, and they've not managed to improve their quality? How do you deal with the negative outcomes of a program? You might improve access to services. One of the things you hope that obviously hospitals hope to do is reduce the inappropriate bypass of the hospital. And if that happens, does the hospital have the capacity to do that? So if you start bringing people back in the community and they don't do a very good job for them, how do you deal with that negative outcome? There's always a downside, and it's important to be aware of it. Now, here are a couple of tools, and we'll talk about other resources, but in terms of thinking about writing good outcome statements, the acronym and the mnemonic that everyone uses is SMART: objective, specific, measurable, attainable, results-oriented, and timed. But think about as you go through, who or what are we doing and who are we trying to impact? Think about then, the change, desired effect in what is the change that we're making, and by when. And then that really helps to write a more effective outcome statement, and that's a small tool that you can use. As I mentioned earlier, here's another tool that helps during the planning stage. Who wants to know about your program? How much information and detail? That really drives how much information detail is necessary. If it's you and your staff or participants, they may need much more detail about when things are going to happen, how, when, who's involved. Other flex programs are going to have a need for your information. The one thing that's always struck me across the 45 states is how willing the flex programs and the hospitals are to share information. And that's I think, one of the tremendous strengths of the flex program, is that everyone's willing to share their knowledge, but how much detail do you share, how much do they need? And that can sort of help drive how you craft a logic model. There are other hospitals. Is it your funder? ORHP obviously wants real specific outcome data and results. So it's useful to use these tools to sort of clarify and think about how each stakeholder might access your data and might want to use your logic model. So I'm going to use an example from Washington State. This goes back to some work we had done a while ago, so it's not as current, but I think it rolls up and will let us describe and think about the evolution and the use of the logic model. And this, Bev Court, I think, was the flex coordinator at the time. I know Bev has moved on, but we worked with her around the development of the Rural Healthcare Quality Network, and I don't know how many of you are familiar with Washington's RHQN, but it's a very successful, well-developed network that focusing on quality that I think is a great model. And then when they sat down, their initial problem definition was that existing quality improvement programs were not relevant to the small hospital environment. Many of you have reached the same conclusion. That was the problem that they chose to address. And there were assumptions that they made was that a rurally appropriate QI program organized through a network of CAHs will demonstrate that CAHs can deliver good quality services, at least comparable, if not better, than many urban hospitals. They made the assumption that strong administrative and clinical leadership was critical to building sustainable networks, and that a QI network that can produce value over time will also be sustainable. They recognized that over time it wasn't possible to think about for Flex to completely support that program, and so the hospitals, to continue investing in it and finding other resources, would need to find value in it. So that's where they started from. And I apologize, you probably can't read this. I know Nicole sent the slides around earlier, but I tried to sort of drop into different components of this graphic for the logic model, some of the component pieces that we can go through. Now, I will tell you that that the problem statement, I think, is solid. I mean, it clearly captures what's going on. But it may not be really specific enough. I think that knowing and working with Bev and the folks in Washington at the time, they really did have an idea what the underlying problems are. But in terms of conveying that, the statement at the time didn't do this. Now they've evolved and they've done a tremendous job, so don't take that as a criticism. And their goal was to build a sustainable quality improvement system specific to the needs of the small rural hospitals in Washington. Their inputs. They created and Washington had done some work with small networks, and they learned from that experience. So their inputs, they had an executive director for the network, they had a medical director, they had a chair of I believe was a hospital administrator of the network. They hired a nurse consultant that worked for the state. They had some of their resources and inputs with the clinical staff and administrative staff in the hospitals. Some of the outside players that were involved included the Washington State Hospital Association, the Washington Health Foundation, excuse me, the Association of Washington, the Association of Washington Public Health Districts, the Department of Health Science Learning Survey and licensing folks. They had membership fees of $2,500 per year, plus a commitment to use $6,500 in services that the hospital would purchase from the network. And they committed roughly $120,000 early on, plus the cost of the nurse consultant salary to the program and fringes. So that's what they input into the process. And their strategies were to develop the network, which included developing a governance structure, membership requirements, administrative systems, video conferencing systems, so that the members could participate and interact without travel, and a QI program that met the Medicare conditions of participation. They also wanted the network to obtain a coordinated quality insurance program, quality improvement program status. And what that really meant is that it was a vehicle that would allow the network to function as the intermediary for peer review and quality assurance activities that would preclude that knowledge being discoverable in a legal action. So they really wanted to be able to function as a protected, safe vehicle. wanted to set minimum standards of participation for the members for at least 3 Medicare conditions of participation around peer review, credentialing, and annual performance evaluation. And they wanted to develop a QI benchmarking system focusing on patient satisfaction, patient safety, and at least 1 clinical collaborative project. So it's a pretty solid and robust strategy. And set of activities. And their outputs, they wanted over time to have a completed, one of the outputs would be a completed business and strategic plan. How would the network go about doing it? What would it need to accomplish its outcome, its desired goals? Policy and procedures manual for peer review discussions. How would that take place? How would hospitals interact and solicit and secure the peer reviews? How the staff would work with them? Defining the minimum standards of participation. They're not standards of participation. I'm drawing a blank now. I'm sorry. Standard procedures that they would follow up with. They wanted a completed CQIP application, which was, as we'll get to, was an important issue for the program and an interesting example of a bottleneck. And then quality measurement tools for patient satisfaction, patient safety, and the clinical collaborative. As they went through, and at the time we visited with the folks in Washington, they were making great progress in getting the strategic plan done, the policies and procedures, and getting the hospitals engaged. And they made the point that it was really important to secure the CQIP status, which would allow the hospitals to interact with the network without fear that disclosing a patient safety problem or a peer review problem would be discoverable in a court of law, and that the network could function. Now, that wasn't happening as quickly. It's a much more complicated thing to get established. And as we looked and talked with them about their timing, that a lot of their ability to recruit hospitals to the network was contingent upon getting the CQIP application done and approved. And so we were able to talk to them about the timing and where that fit in the priorities. That could have been a very big bottleneck that would have inhibited production and the accomplishment of some of the other outcomes. And we have a question that is important here, not just put outputs in the short and medium term outcome categories. Something happens that can just be an output. And so what's the test for something being an output or an outcome? And as you look at some of the short and medium term outcomes under the red arrow, there are some things that are sort of gray. They sort of fall halfway between an output and an outcome. Again, I think an output is a little earlier in the chain. It's the product that is desired to change knowledge or change behaviors. So the real test for whether something to me is an outcome or an output is the extent to which we expect that to drive a change in what the participants know or what the participants are doing. And an output is something that's more easily countable in terms of a product, be it a meeting, be it a tool, be it a resource, is it a policy manual, is it a strategic plan? Those things are outputs. And you may have outputs depending on implementation of new activities in middle years of a program. But that's really something I think you can address individually and think about. But you really want the test to be whether something is changing and whether that outcome can be a measurable change in the knowledge, behaviors, or status of your target population. And I won't go through and read all of these logic model, the outcomes, but suffice it to say that these outcomes were really about moving their goals. So under the short term, they wanted an effective operational structure in place by August of 2005. They were able to do that. They wanted operational documentation completed. They did that. They were receiving contracted services, all of those things. So somewhat leaning more towards the outcome rather than output. But as you moved along, one of the outcomes, short-term outcomes, is that they wanted the hospitals to commit to continued participation in the network. That's an outcome. It's a change in knowledge and status and a commitment towards moving forward. They obtained their initial CQIP status by December of 2004. And so here you start seeing some things that are more measurable outcomes. They wanted 90% of the participants to meet or exceed the RHQ and defined minimum standards of participation. They wanted members to adopt the quality measurement tools, so that's a change in behavior adopting those tools, and that at least 80% within the short term, which would be 1 to 2 years, would have adopted at least one common clinical quality measurement tool. And so these are short-term things. As you move further along, one of the outcomes is the increasing the number of participating CAHs that are involved. They wanted to see, and this is certainly an outcome, that a larger proportion and percentage of the expenditures for the RHQN were self-supporting. So the hospitals found enough value that they were willing to commit their own resources to help pay for that. Participants were meeting and continued to meet the standards for the Medicare conditions of participation. They moved the number up to 95% of participants meeting the minimum acceptable standards of performance. They demonstrate higher patient satisfaction scores over time. And in the long term, they wanted a fully sustainable network in place by 2007. And Peter House just reminded me that to remind me that RHQN lives on. I recently spoke with Randy Benson around another project, and they are really doing great work. And they're a long way towards achieving some of their goals. Their goal was to have more than 50% of the expenditures supported by the hospitals. They wanted the network participants to be engaged in national quality initiatives. 100% of the participants were meeting the minimum standards of performance. These are aggressive goals, and these are really outcomes. So you documented changes. They exhibit. I think they wanted to see the hospitals exhibiting appropriate patient volume and utilization. Bypass is a tricky thing to talk about because some bypass is appropriate. One of the ideas behind critical access is to create hospitals that are able to manage within their resources and not doing things that they don't have either the resources or the capacity or the volume to do well. So that was something, and that's an outcome. They wanted less than 25% of patients inappropriately bypassing the hospital. So if the hospital could offer a service with appropriate quality and at a fair price and with good patient satisfaction, they wanted to see that reduced, and that was a strong goal. So that gives you an idea of how that rolls up. Some of the outcomes over time, I think this was one of their first passes, became more targeted and more specific, but you started seeing places where measurement can take place. So 100% of the hospitals meeting state licensure standards, less than 25% of patients inappropriately bypassing the hospital, 100% of hospitals able to achieve insurance coverage, which was an issue at the time, meeting standards of performance. Mary, back excuse me, to your question regarding how you measure changes in knowledge. So if one of the issues that are uncovered is that the quality improvement staff or the staff doesn't have, the staff in the hospital are not up to date on current and the latest quality improvement activities going on nationwide. They're not familiar with measurement tools or some of the collaborative protocols. You can do in-services, you can do trainings, you can do TA. You can link people up through collaboration with other hospitals that are successful in the network. And you can measure that by showing the extent to which they're looking at and adopting some of the new tools. They're participating in the network, participating in the resources that are available. You can do it through, you can do surveys, you can do evaluations following training. If obviously you've done a lot of training in one hospital and they're still not adopting any of the tools that are available to them, they're not participating in the network, or quality is not improving, you've got to look at whether or not knowledge has the knowledge changed, and that really can be done with the individuals directly. Is it a resource issue? Have you had a turnover in leadership? Has there been a loss in staff? There are any number of things that might impact that, but you can get at that by really working with the hospital staff. And I won't go through too many of these because it really talks about some of the things that are in the tool and the template that I provided. But really looking at government structure, membership, and really very, very practical things around establishing the network. I think one of the questions, there was a question that came up, can you print the presentation? I think Nicole attached it to the reminder that she sent out today, so you should be able to do that. You'll have it in PowerPoint form. Going back to the governance structure, so there are, in developing the network, there were very practical administrative things. Then there were programmatic things around developing the clinical QI program, identifying what they needed to do to meet the conditions of participation. They wanted coordinated QI program status and minimum standards that the hospitals would agree to, and a clinical benchmarking system. And I think it's safe to say that they've accomplished and they've implemented all of those strategies, and I think are showing real evidence that they've been successful and are having the outcomes that they want. Some of the planned outputs, as we mentioned before, were very practical things: business strategic plans, policies and procedures, having the minimum standards of performance agreed to, and the clinical measurement and the quality measurement tools. And this will just give you more information about how they measured some of their initial outcomes and what they did. They wanted an effective operational structure in place by August 5th of 2005. And how they measured that, they had completed operational documentation, that hospitals were receiving contracted services during that year, and that hospitals were committing to participate in subsequent years. So you can see how they rolled up each of those set of initial outcomes. Same with the intermediate measures. They wanted network increases in capacity through August of 2006. They measured that by the number of participating CAHs. A greater percentage of revenues and expenditures were being supported by the hospitals, and they've implemented and they identified their focus areas. Now again, remember that some of these things are a little gray between an outcome and output, as long as the body of what you're doing in total is moving you towards changes in knowledge, performance, or status, then you're really moving in the right direction. And notice that these things are often measurable. So the scope of the CQIP was important to them, and that one of the goals and an important outcome, but it really was a critical to gaining participation was that peer review discussions were shielded from disclosure. Without that, it would be much harder for them to engage hospitals and deliver services. And the long-term measure was that sustainable productive network is in place by August of 2007. All of their hospitals are participating. I believe that is indeed true. That more than 50% of their expenditures are self-supporting. They're participating in national initiatives, and they've really moved that along. Excuse me, my voice, I'm getting a little bit hoarse. And another set of what they've done. They said 100% of their participants were meeting the standards of performance, QI licensure standards, and are able to obtain insurance coverage. And those are very clear, measurable strategies. I have to say I'm not sure how they were measuring the bypass question, but it's certainly a measurable goal. I'm not sure how they were getting to that. But it's clear that they were also being able to show improvement on the established quality measures. Challenges and some of the lessons learned as we dealt with and helped work with Washington to develop their logic model is dealing with complexity. There was a lot of complexity trying to convey everything in a single logic model, and we kept working with them to pare it down to the essence and understand that we could use catchphrases and individual components. We didn't have to illustrate every step along the way. You had to know what they were, and you had to know how to implement, because that's part of your implementation strategy. But the logic model is designed to convey that information in a summary form, so not everything has to be there. Failure to depict the underlying rationale. Our job when working with the folks in Washington was really to ask questions. We were to be the devil's advocate, if you will, and that's always helpful to find someone to fill that role in developing a logic model. Is asking questions. So what if? Why? How do you expect that to happen? And really refining that. It's difficult to write these things perfectly on the first pass and iterative process. And so thinking about it in those terms really helped to clarify what they were what they knew and were explaining and trying to convey. Challenges in terms of outcomes and measurement. The outcomes really have to drive from the targeted causes of the problem. You've defined a problem. Then you measure how you intervened and changed that problem, and they have to drive from the root cause analysis, which is important. And root cause analysis is a quality improvement strategy that many folks might be familiar with in the hospital, and the same holds true for the FLEX program. And those measurable objectives come out of the outcomes. Not every outcome can be measured. Can you measure the important ones? Can you put together a body of outcomes that show that you're moving in the right direction? An inability to specifically measure or collect data on one outcome isn't a failure, but as long as the sum total of your work is moving you in the right direction, I think you're good. And lessons. It's a process that requires some careful examination, some soul searching, some introspection, some willingness to question what you've always done or interventions that you've leaned on in the past. They may not be bad things, but maybe there are things about them that could be changed that would have a better impact and better outcomes. But it really requires a willingness to think about where you are, what you're doing, and how it fits together. As you do that, new program design and improvement options may become evident as the program has its impact. If knowledge and capacity of the program staff and CAH was an initial targeted problem, if you've addressed that and you've had consistent staff in a hospital and they're more comfortable and they're aware and they're fully up to date on the programs, the interventions need to change to focus on helping them implement versus understanding. So the program evolves as you have success, you move to greater and higher levels of attainment. Really helps to helps priority setting by you identifying those critical elements. In this case, it was really I think, a bit of an eye-opener because they were focused on getting a lot of the practical things together, and the CQIP was more difficult to implement at the time and took a lot more resources. That was something that wasn't as high on the priority scheme, but we were able to talk about, and they were able to understand through just our asking questions, just how much of a barrier that could be to success, and so they redoubled their efforts to get that done. And just sort of going back through some other examples of outcomes and measures I looked at, and with some resources from Tracy at TASC and from Megan and Mike at ORHP, began to think about examples of how you might look at these outcomes and measures from sort of different areas. And one is to support development and implementation of evidence-based protocols. I pulled some of these directly out of Flex applications and some of the tables that were done, so these may seem familiar. The outcome was increased CH utilization of evidence-based protocols, an important tool, and improved hospital quality of care and patient safety. And so the measures that I saw in the tables, at least in terms of the first active outcome and measuring those that are using evidence-based strategies, that's more of a shorter term to intermediate term measure. They were measuring the number of CHs using evidence-based strategies. That's a good measure. Improvement in hospital care wasn't particularly specific. We knew what they were going at, but it was important in thinking about that. How would you measure that improvement in quality care? Is it going to be through using hospital compare strategies? Is it going to be some internal process measures? But it's helpful in thinking about documenting that outcome, how that state would measure it, what the source of data would be, and what the targeted percentage improvements are. Another activity was support efforts to reduce unnecessary hospital readmissions, a very big thing in today's world. The outcome, obviously, was a reduction in CH admission, unnecessary readmissions. Their first measure was a number of CHs implementing their readmission guides and protocols, and then the second measure was reduction in preventable hospitalization readmission rates. Two very specific measures. It would be helpful to set targets as you think about moving from short to long-term, and the program implements, realizing not every hospital is going to play. I've spoken to hospital flex coordinators who struggle with this issue. They have good tools, they have good resources. Not every hospital is going to want to participate, and you've got to decide what your targets are, where the sticking points are and where the leverage points are, and setting some measurable targets. Another core financial performance improvement, and I embellished this one a little bit. One of the efforts to efforts to improve CH business office and billing operations. The outcome was that the CHs who were participating would exhibit better cash flow and improve viability. Obviously, one is the number. These are sort of a number of measures. One would be the number of hospitals participating in business office and billing operation trainings and interventions. Excuse me. Another measure that would be a good one is that the number of CHs have improved the turnaround time to bill third-party carriers. The ability to improve cash flow depends in part, one aspect is how quickly you get your bills out the door to third-party carriers. Another is how accurate they are when they go out the door, but a good measure might be reductions in turnaround time. That you would reasonably expect you to believe, all things being equal, that you're going to see improved cash flow from billings. the number of CHs with improved cash flow, and you can measure that in a number of ways, and the number of CHs with improved margins. These are very specific measures that are showing that you're having an outcome. Now, those latter two, there are things that might go on within the environment that you can't control, but you can develop those chains that will show that all things being equal, this will happen. And if something else comes into play in the environment, I think you've got to be aware of that. And the last is comes from the core area of community development engagement. Encourage and support CAHs by identifying options to address gaps in local gaps in behavioral health services. This comes out of a specific state, and the outcome was and as I read their plan, it struck me that it was a great idea, but it wasn't necessarily broken down in this way to get to some measurable outcomes. So you really want to, an outcome is improved availability of behavioral health services. Another measure might be improved collaboration between CAHs and behavioral health service providers so that you're moving in that direction. And ultimately, that's improved patient care in the CH communities because they're getting an important service that may not have been available. So measures, the number of CAHs that have received TAA to support develop behavioral health services. An interim measure is looking at the number of CAHs engaged in efforts to develop behavioral health services. Are they involved in collaboratives? The number of CAHs are collaborating with local providers to sort of make the system work better. And an ultimate measure that would lead you to believe you're having you're improving patient care and improving patient outcomes is that the number of CH communities where behavioral health services have either been implemented or expanded. So again, rolling up those measures in a way that makes sense. I have a comment that another way to label activities here are goals, objectives. The goal is to support efforts, and the activity is to provide workshops, toolkits, and consulting. And I think that's exactly right. That over time that you can look at these things moving backwards from your desired outcomes and setting up the stages and how you do it. These, the terminology, I think, is what works best for your logic model, but I think that's an excellent point. And finally, some resources that are available. We have a toolkit on logic modeling, much of which was developed through the work we did with some states in Pennsylvania and Washington. I think we had Arkansas and Nebraska were involved. Also go back and look at the No-SOAR Performance Measurement Project. That was a project that Matt Chandler and I had done for them. It was a very interesting project. We developed some recommendations and measures. We also developed logic models that I know John Barnes from Michigan and others found helpful. And the links to some of these toolkits are on my slide. W.K. Kellogg has a logic model development guide that's a little, that takes a slightly different focus than mine. It's a more broadly focused on evaluation. Certainly you want to talk to the folks at TASC. They're the folks that can help and are tasked with supporting the states and flex programs in implementing and developing their work, and they're a great resource, certainly knowledgeable about the program and what states are doing, and they're on top of where a lot of states are in a way that is amazing. The Targeted Outcomes Program Framework, this is a resource that talks a lot about setting up those outcomes and working with outcomes, and a tool that I found useful. Unfortunately, it's for purchase only, but it's only $5, which is a United Way measuring for program outcomes, very practical guide. So these are some resources. There are others I'd be happy to share with folks as we go along. I'll open it up for questions.
John, this is Tracy Morton.
Hi, Tracy.
Thank you very much for presenting today. This is great. Mary Sheridan had typed a question earlier in the chat about your suggestions about how to measure knowledge change.
Yes. Ways to go about it. I think if you're doing a training or you're doing technical assistance, you can implement an evaluation form that sort of lets people tell you what they've learned and feedback. You can do brief interviews and surveys. Sometimes one of the clearest evidence of knowledge change is performance. If they're beginning to be engaged or they're asking the right questions, obviously that's not as specific a measurement, but if they're moving from a sort of a state of not being very engaged in performance measurement and quality improvement to implementing and engaging in a network, implementing specific procedures, then you've got evidence of your knowledge change. But a lot of it can be done as sort of an evaluation, much as when we go to meetings, but with a more targeted evaluation or feedback instrument. Another question says, if you're using the logic model to garner support for your program, should you include the results of your literature review, evidence of what you did, and how it's worked elsewhere in your report, or is it too academic? I think that depends. I think that if you're talking to key sort of broad level stakeholders, it may not be necessary to put that evidence in the logic model in the report, but if you're using it as a program development and a planning and evaluation tool, very clearly that is useful. The way that I've used logic models and that process, if you're being asked to implement an intervention, and I think about some of the grant reviews that I've done for the office and for other funders, too often they talk about an evidence base, but they don't provide you with enough information to know whether or not that evidence, how it works, or in what situation is in what context. So I think for program planning, for evaluators, for program management staff, absolutely. If you're sharing it with key stakeholders to give a sense of how your program works, that may be more detailed than they need. And so that's a very definitive question. It depends. And it depends on what you're using the tool for and how you're trying to communicate and what you're trying to communicate. Other questions?
I haven't used logic models before. It might be helpful to have some examples, and I was just sketching out some things for our plan, and I'd be happy to share those around if people are interested. Maybe I could send it to Tracy in task, and she could send it out.
Sure, and I've got some other resources on different logic models for programs that I'd be happy to share as well. The toolkit that we did has some examples. It's on the Flex Monitoring Team website. We had great participation from our study states that were engaged with us. But it talks a lot about the models, and it provides you with some forms and tools. Again, I think to me the real work is in the planning and development that gets you to where you are in terms of measurement and program strategy and theory. I've got a lot of resources on those materials, and I'd certainly be happy to share. Tracy, if it makes sense, I'll collect a few of those over the next week and send them to you, and we can make them available.
That would be great. And John Ike, if you'd like to send along the same, then we could distribute them out as well. That'd be wonderful.
I know one of the ways that John Barnes was saying that he used his logic model for the state office performance project was it gave him a way of communicating with legislators in Michigan to just in a clear snapshot, this is what we do, this is why we exist, this is how we have our impact. And he found it to be quite helpful in meeting with folks in terms of securing funding as some of you may know, Michigan had a very interesting dilemma where their funding was in jeopardy, not because of poor performance, but because of the state's budget situation. And John, using some of the tools, not just the logic model, but certainly his power of persuasion and the evidence that they had for the work that they've done across the state, had been able to reverse that decision. But having those tools was an important part of what he needed.
Other questions for John? It's star pound to unmute your phone. Okay, I think I'd also like to suggest that maybe we can, as a group, continue with follow-up in the FLEX program forum about discussions with logic models, how some of the FLEX programs are beginning to incorporate those into